Good evening, everyone. My name is Jerome Evans, and I am one of the co-chairs of the Public Health Advisory Committee. I'd also like to introduce our other co-chair, Laura Rangard. Please wave, Laura. Thank you. Before we begin, I'd like to note that this meeting includes the remote participation of members as authorized under Minnesota statutes section 13D.021 due to the declared local health pandemic. I will now call this meeting to order and ask Hattie to call the roll so we can verify the presence of a quorum.
Okay, Terry Ann Jones.
Present.
KJ Starr. KJ Starr. No. Mary Pike.
Here.
Kozar Mohammed. Kozar.
Kozar usually comes late because I think she has a class or something that happens on this same night. So she may pop later.
Yeah, I just heard the doorbell, but it looks like it was Gretchen. I just wanted to make sure it wasn't her. Lisa Nicotra is not going to be here tonight, correct? Anna Arkin.
She's just coming in right now.
Oh, yeah. Anna
Maybe
Arkin, are you present tonight?
Hi, I'm here. Just joined.
Thank you. Fatima Jaffer.
Here.
Did I just say your name wrong?
No.
Okay, just sorry. I was talking about I'm tired, and maybe what I heard and when I saw it didn't come out right. Alicia Jackson is not here tonight, correct? Laura Rangard.
Present.
Jerome Evans.
Present.
Andrew Crook.
Yep.
Britt Culp is not with us tonight. Wanda Felder. Did we get an email from Wanda as well, Margaret? Meredith Martinez.
Here.
Craig Hedberg.
Present.
Babette Apland. Babette Apland. Aaron Hurley.
Here.
And Julie Punjabi.
She's just coming in. Anjali is just coming in, yeah.
Anjali, are you here?
Yes, I am. Sorry, I had some trouble logging on. I'm here now.
Oh, good. Glad you made it. Okay, we have 11, so we have a quorum.
Awesome. Thank you, Hattie. And
Hattie, I believe it was Babette Apland who had emailed that she was not going to be able to attend tonight.
Okay, I think that makes everyone accounted for. Wonderful. So per usual, we are going to vote on the agenda and the minutes from the last meeting at the same time. But I just want to make sure, is there any discussion on last month's minutes before we vote to approve them and to approve the agenda? Seeing none, Mary, you're unmuted. May I have a motion?
Yes, I would like to make a motion that we approve the minutes from the August 24th, 2021 meeting.
Thank you. And the agenda for tonight's meeting?
And the agenda for tonight's meeting. Thanks, Jerome.
Thank you. I appreciate your formality in that motion. Andrew, it looks like you are unmuted. Would you mind seconding?
I second.
Fantastic. Hattie, will you please call roll on the motion? Oh, you're muted, Hattie.
You didn't hear all my witty comments either, then, did you? Terry Ann Jones.
Approve.
KJ Starr. Mary Pike.
I must refrain because I was not in attendance at that meeting.
You can still approve them.
Oh, then yes, I approve them. I did read them. I approve them.
Kozar joined us yet? Anna Arkin.
Approve.
Fatima Jaffer,
Approved.
Laura Rangard,
Approve.
Jerome Evans,
Approved.
Andrew Crook,
Approved.
Andrew, you might be on mute.
Wanda
Approve.
Felder, Meredith Martinez,
Approve.
Greg Hedberg,
Approve.
Aaron Hurley,
Approve.
and Julie.
Approve.
Okay,
Awesome. Thank you very much, Hattie. So those were approved. We are next going to move into a presentation on promoting and addressing mental health in Hennepin County. As you may recall from past discussion, mental health kept coming up as an intersection with a lot of the priorities that we've already identified, and that we'll be talking through a little bit later on in this meeting. And as it so happens, committee member Meredith Martinez was willing to present to us today, and she came with some colleagues. So Margaret, unless you have any further intro, I'm going to ask Meredith to take it away. Awesome.
Great. Give me just a second here to pull up my slides. All right, do you guys see the slides? Awesome.
Yes, we do.
Great. Okay, well, so I'm super excited to be able to present at the meeting tonight to you all, just because I've been in those conversations recently when we've been talking about the importance of mental health, and there happens to be a lot happening at Hennepin County around promoting mental health and addressing mental illness and disparities in this area. So I just want to make sure we have an opportunity to, oh, there's a hand up.
I do not see the slides, just a black screen. Is
Yeah, I don't
anyone
see them
else-
either.
Okay.
I don't see them. Okay, well, let me see. Does anyone else see them?
Yeah.
Yeah, I can see them.
I see them.
Yes, I can too.
Me too.
Jerome, did you say that you could not?
I can see them.
Okay, well then I think it must be some problem on my end. So I'll just be a diligent listener.
Okay, hopefully.
Mary, I can email the slides to you.
You're muted, Mary.
I think they're also attached within the agenda itself. So I don't know if you're able to pull that up, Mary.
I will try. Thank you.
All right. So I wanted to make sure that Leah and Cindy have an opportunity to address the group and to introduce themselves. So I'm really fortunate that I have really awesome colleagues with me here tonight to present. And so I'll turn it over to them if they want to just say who they are and say hello.
Sure. Hi, guys. I'm Leah Kaiser, and I am the Senior Department Administrator for Behavioral Health in Hennepin County in Human Services. Nice to see everybody.
Good evening, everybody. I'm Cindy Sloviak, and I am the Human Service Area Manager in Behavioral Health, which is part of Human Services. Nice to see you all.
Great. So I'm going to be kicking us off here, but, oh, just happened. Did someone just start sharing their screen? Do you guys still see the slides? No, I don't. Weird. Okay, let me try again. All right, can you see them now? Excellent.
Yes.
Okay. So Leah, Cindy, and I will be jumping around a little bit. We're each going to be taking a few of these slides. We'll try to go through them pretty quickly so that we make sure we have time for questions. So I will just start at the beginning just to give you a highlight of what we're, actually, there's a little bit of an echo. So if anybody's not muted, if you could mute yourself, that would be great.
That's me. Sorry.
Thanks, Margaret. So we can give you an overview of the current landscape of mental health in the county. We touch on a little bit of the scope of services for children and youth as well as adults. And then just a brief little snippet of some of the work that we're doing with public safety and a partnership that we're doing there. So today's presentation focuses on the work that we do within Hennepin County, specifically human services and public health departments. And even though we are under the same umbrella, we do have different approaches and different services that we provide. And I think one of the really nice things that we've been able to do over the last several months in putting together a plan for promoting mental health and behavioral health is to work together to determine a continuum of services for Hennepin County residents. And we'll talk a little bit about what that looks like as well. One other thing to note is that these slides are an adaptation and a scaled back version of a presentation that we did to the Hennepin County Board of Commissioners. So we've been able to provide a lot of information to the commissioners about behavioral health and mental health. So I will just get us rolling here. So just to ground us a little bit in terms of what we're talking about, I think most of you are familiar with the concepts that we're going to be covering today. But we know that mental health is at the core of well-being. Mental health is central to overall good health, and it intersects with a lot of other areas in our lives. So that's why this work is so important. And why, when we talk about mental health, as you'll see throughout this presentation, there are a lot of other areas that are important to address in order to make sure that mental health is in place for our residents. Mental health is also about reducing health disparities, and the efforts in this area need to work closely with other areas, as I mentioned, within the county. So I am going to turn it over to Leah. Go for it, Leah.
Okay, so just some level setting. So mental illness are conditions that impact a person's thoughts, feelings, and behavior. They're considered fairly common conditions in the general population. Every year, about 1 in 5 adults and 1 in 6 kids are going to be diagnosed with some type of mental illness. There are estimates that suggest that up to 50% of the U.S. population will develop a mental health disorder in their lifetime at some point. But most disorders, especially serious disorders, beginning in childhood and in adolescence. There's hundreds and hundreds of different types of diagnoses and a whole bunch of ways to categorize them. They range from mild to serious, and the impact to the person's functioning can also range from mild to severe. Let's see. Can you? Yeah, you got it. Okay. So if you look at the Hennepin County adult population, we have about 1 million people. It's a little more than that. Of those, roughly 200,000 will be diagnosed with any type of mental illness, and 50,000 will develop a serious mental illness that substantially interferes with their functioning. The areas that we tend to look at is family, community, school, and work. So when we do functional assessments, those are the key areas of life functioning that we focus on. About 25,000 will eventually go on to develop a very serious condition that is classified as a serious and persistent mental illness. Those are defined in statute, and it's not only a diagnostic determination, but it also includes, like I mentioned, serious functional limitations, the severity of their symptoms, and the use of more restrictive services like hospitalizations. Next slide, please. Okay, so then looking at kids, the number of children and youth living in Hennepin County between the ages of 6 to 18 is approximately 200,000. About 17.5% will be diagnosed with any type of mental illness, and 10% of the total population between 6 to 18 will develop a serious emotional disturbance. Just a quick note on this for kids, we don't use the same categories of serious mental illness and serious and persistent mental illness because of how diagnoses are categorized for children versus adults, given that kids are still in development. Okay, next slide, back to you, Meredith.
Yeah. So again, this is just a graphic that reiterates what we talked about earlier about how mental health relates to social determinants of health, really looking at the impact of mental illness on overall health. If you look at the impact on housing, 21% of people experiencing homelessness have serious mental illness. We also know that there's correlation with income, unemployment and financial stability, as well as education, transportation, and justice. So when we talk about mental health promotion and reducing disparities, this is really needing to look at an overall picture of these social determinants of health. The county's role in the mental health system is one of partnership with the state. So the mental health system is governed through the State Department of Human Services. We at the county work really closely with them to advocate for good policies that improve lives of residents in Hennepin County. We are always taking our role and applying an equity lens and really putting effort into reducing disparities. As well as assessing the needs of our communities and maintaining a healthy network of community providers. We also leverage federal and state funding streams and provide gap funding for services. And then this is just another graphic, again, showing the services on a spectrum or a continuum by age. So we'll touch on a few of these things today, but really thinking about, we're lucky to have a wide range of services, both contracted and county run across the age and intensity continuum. So there are community-based programs such as we've got like community supports. We also have outpatient. And then there may be some instances where, we provide a service one time only to someone who needs it, or there's ongoing services for those who need it. So we have, low level intensity. We have medium level intensity, which may be every other week to weekly, and then high intensity, which could be daily or 24/7 services available. Let's see. Also, a couple of points here is, and I'll reiterate this later on too, is that early engagement and prevention really helps to prevent deep end intervention or the need for deep end intervention. So as we work together, both public health and human services, we're really cognizant of that investment early on in early childhood or, early on in any mental health concerns. Community-based services help people stay in the least restrictive settings, and emergency care helps people move from mental health crisis to recovery. Compared to most places in the country and our state, Hennepin County has a broader range of mental health services that span from low intensity to high intensity. In Minnesota, many needed mental health services and supports are funded under Medicaid that are not funded under Medicaid in other states. Outcomes by program, including those from several county-operated adult mental health programs, are very good. And many of the service models available in Hennepin County are supported by national evidence and local findings for what works to be effective at treating adults living with mental illness and children with emotional or behavioral conditions or concerns.
So the research in this area tells us that the first time that most people seek help for their mental illness, tends to be 10 years after symptoms first appear. And white people tend to access supports at a higher rate than Black, Brown, and Indigenous people. So, for example, 50% of white adults versus 33% of Black or African American adults access formal mental health supports. We know that lack of access is one of the most salient factors that creates an inequitable system. Evidence around what works in treatment also tends to mask hidden disparities in program effectiveness. So there's very few empirical studies in the mental health field that have validated treatment specifically for people from diverse cultural backgrounds. The current model, as Meredith mentioned, is heavily funded through Medicaid, and that Medicaid model tends to support a medical model that doesn't fund interventions outside a more westernized approach. So we know that how illness is understood requires cultural considerations, and that stigma exists around mental illness. There's a distrust and fear within many communities that have had traumatic exposure in government programs. And language differences create obstacles to persons' ability to access and fully participate in the variety of interventions that we do have. So the collective impact on these obstacles compounds the barriers that Black, Brown, and Indigenous people face when seeking help for mental health. I'm now getting a bit of feedback. If those could. Oh, there you go. You got it. Thank you. Next slide, please.
Yeah, so I'll just cover this pretty quickly. One of the areas in public health that we focus on quite a bit is early childhood mental health. And we work closely with Cindy's area as well to focus on this. So the role of public health in this is really to promote mental well-being and mental health starting in early childhood and continuing across the lifespan. So our role focuses on prevention and early intervention and well-being. We take a holistic approach to mental health, which includes promoting exercise and activity, diet, nutrition, healthy relationships with others. It also includes addressing, to the extent possible, social determinants of health, providing families with basic needs, food security, and really trying to support the family unit so that in turn helps promote early childhood mental health. So just really quickly, when we talk about early childhood mental health, what we mean is really that we're talking about a child's relationship with parents, caregivers, relatives, teachers, and peers, and how these relationships shape the architecture of their developing brain. So social emotional development is also known as infant and early childhood mental health. It's basically, the definition is the developing capacity of the young child to experience, regulate, and express emotions, form close and secure interpersonal relationships, and explore the environment and learn in the context of a caregiving environment that includes family, community, and cultural expectations for young children. So that's a very broad definition. And as you can see, the mental health of a child and an infant is very dependent upon their relationship with their caregivers and the world around them. So when we talk about mental health interventions for children, thinking about how to address that is really how do you address the needs of the family and the caregiver. So in public health in Hennepin County, we've got several programs that promote mental health, children's mental health. And those approaches typically include early identification through screening. So we do mental health or social emotional screening and are able to refer children and families to resources that they might need if there are concerns. And then also providing parent education or caregiver education and support, as well as information and skill building around child development for those caregivers. Two specific programs that we have that were highlighted for the board include a partnership that we have between public health nurses and children and child protection in out-of-home placement and the screening that we do for those kids. And then family home visiting, evidence-based family home visiting is also another intervention that really supports this. So just to give you a quick snapshot of that evidence-based home visiting, there's some data here. We in Hennepin County have home visiting that's delivered through contracted providers through multiple programs and models. The city of Minneapolis also has their own home visiting programs and services. So they also, you all also provide these services to residents in Minneapolis. So just wanted to show some facts here where evidence-based home visiting does show effectiveness in parent support and supporting the mental health, both of the caregiver and the child.
So I'm going to talk just a little bit about what Hennepin County Human Services is doing related to children's mental health and the types of services that we provide. As Meredith said earlier, we work in ensuring that there's a viable continuum of services through a combination of both contracts with providers in the community and services provided by our own staff. We currently have 68 contracts with various providers in the community to provide the array of services you see listed on the screen. And roughly that array of services is touching around 3,500 youth a year. We really want to focus on the outcomes of improving the ability of children to function in their home, school, and community, and to support their family and caregiver to be able to respond to the unique mental health needs of their child. So these services, like as Meredith was saying just a few minutes ago, that when you work with infants through children as they age out, when a child has a mental health concern, it impacts the whole family, not just that child. So the approaches are really focused on both, improving the functional capacity of the youth as well as working with their families to be able to provide that support. In terms of Hennepin is very intentional in contracting with provider agencies. We're well aware of our the stigma around mental health, and that it gets exacerbated with a connection to Hennepin County. Often when people think of Hennepin County, they think of child protection, and then they're less likely to reach out if it's a Hennepin County service. So we're very intentional about using our provider community to eliminate that barrier to access. We also realize that in order to really work well and provide this continuum of services, we have to collaborate and integrate across systems. Children are involved in the education system, the health system, as I said, the child protection and juvenile justice systems. So our work also is about bringing all those systems together to have more of an integrated approach to providing services. The one service that Hennepin County Human Services does provide is children's mental health case management. We do provide this on both a contracted and with our Hennepin County staff. Our Hennepin County staff tend to work with the youth that have multiple system involvement, and as a result have a complex set of needs and are often involved with the juvenile court, either through a juvenile justice or child protection case. So we currently have around 20 children's mental health case managers that are Hennepin County employees who provide this service. And they come with a unique set of skills in knowing how to navigate all these various systems, as well as the mental health system, to be able to connect children to the level and type of service that they need. Of our case managers, we tend to have a more experienced group of professionals that work for Hennepin County in providing this service, and their tenure ranges from 3 years to 33 years, with an average about 13 years. And just in one of the things I just also want to point out, that group of case managers tends to work with about 300 youth a year. About 70% of those youth are youth of color. Hennepin County also has been very innovative in our school mental health program. This program started in the early 2000s with 5 Minneapolis public schools. Today, we're able to provide mental health services in the school in 164 schools in Hennepin County, 8 Head Start programs. These services are provided by our community providers, and we work with 16 different providers that provide these services, and we cover around 77% of the school districts in the county. You know, as we really focus our energy around this service, because as Leah said earlier, people are often experiencing services 10 years before they actually get services. We also know that the first place that their symptoms also often show up are in the schools. And so by getting there earlier, we are hopeful that we remove some barriers to trying to get services in the community and get there quicker, to change the trajectory for that youth and that family. So the other thing I just want to say, the funding for school mental health is a bit complicated, as is for a lot of our services. And we fund this service with a combination of property tax dollars, state grant dollars. Some of the school districts contribute dollars as well. And about 70% of the cost is covered through direct billing to private and public healthcare plans. Next slide, please. So the other thing I just want to touch on is children's mental health is right now embracing a pretty comprehensive system transformation effort. And we're utilizing a framework that's called System of Care to do that transformational work. System of Care is not a new concept. It's a concept that's been around for a long time. It was developed by SAMHSA. And what this framework provides is an overarching set of values and principles that are used to coordinate and develop the continuum of services. And as you see on this slide, the fundamental value is that the youth and the parent need to be at the center of all decisions that are made, not only at a direct service level, but at a program operational level, and also at a system policy level. And, you know, as we do this work and we gain more capacity to understand what this means, is it really means that the voice of parents and youth are important in deciding how we allocate our resources and how we structure our system. And it often requires a move away from a medical model approach that Leo was talking about earlier, and to a more holistic well-being approach that's inclusive of the family. So the rest of the values are the cultural responsiveness, the ability to integrate across systems, using data, qualitative and quantitative, to inform our decisions, being aware of the trauma and the trauma impact on the youth and the families, and to be able to engage with that child and family's cultural community are essential to the work around system of care. And then I just want to point out, when in developing a system of care, these are what we call pillars, or the foundational types of services that are necessary. The one on the right, which is the service continuum, is what people often think of when we talk about system of care. And that's that continuum from early intervention to deep end services. We still have to have that kind of array of service. However, wraparound, which is in the middle, is a service model that around delivering care coordination services that really is focused around the values of system of care and really focuses on that holistic approach, as well as that approach to really trying to be creative in how you bring together formal and informal supports to support that youth to stay with their family. So it's a really different paradigm than is often used in medical model defined care coordination. And the last pillar is what we call family response and stabilization. And this is a service model that's been developed at a national level and has been found to be effective in other parts of the country in being able to really support families early when they're experiencing stress related to their child's behavioral or mental health issues. And that service involves direct outreach when a parent reaches out with a sense of urgency and concern and stress, and goes out there immediately to help the family, in some cases, define what the underlying drivers to their stress is, as well as start to help the family learn how to connect with the types of services in the service continuum that will help to support their youth and them to keep their child in their home.
Great. Well,
So, oh, go ahead.
Go for it, Leah.
Oh, okay. So we're going to shift gears a little bit and start talking about the move from our service array from children to adults. And COPE is a nice one to do this transition because it provides services for both children and adults. So in Hennepin County, there is an emergency response, a mental health emergency response. They're a mobile team called COPE. It operates out of the public health department. It's state mandated, so by law, every city has to have one of these mobile response teams. It's available 24/7, provides support to all ages. It runs a crisis call line, so folks can call this number, call COPE, and what will happen when they call is there will first be a phone assessment. An advantage of having this operated in the county is that the person that's handling the crisis call can look up the individual in a bunch of data systems to try to understand, more fully what's happening out in the field. Sometimes they're able to respond with either information or referrals. They're asking quite a bit of information about what does the person need, how acute or how serious is this. Sometimes it's a matter of de-escalation. You can do that either over the phone, or if they're not able to do that over the phone, they have the capacity to go into the field to help de-escalate situations. They very seldomly use law enforcement to go along with them, but they can, if they need to, contact through 911 to get some additional support. This slide is showing, the steady increase of these COPE calls over the years. We saw a decrease in 2020. We saw that all over the mental health system, though, primarily because of stay-at-home orders and people weren't moving around. One of the most common ways that calls come through is by either family or friends or support that are, in contact or seeing something happen. And under COVID, it was like things were much less visible. And that does not equate with the needs, though, of our individual communities. I'm going to go on to the next slide here. And Meredith, will you take this one?
Sure. Yeah, I can talk about this. So just moving along that continuum, public health also has a mental health center, which does serve adults and some children that are already receiving county services. So this is an outpatient mental health center. They provide assessment and diagnosis, as well as medication management, individual and group therapy, and also they have programming and services for co-occurring mental health and substance use. They also do medication-assisted therapy and co-occurring groups for that. They also are in the process of moving into, and I think I'll just maybe go to the next slide. Moving into a new location. They are moving into the South Human Services Hub location on Lake Street. And with that move, there are several new partners that are coming together. So the Mental Health Center will be there, as well as East Lake Clinic through Hennepin Healthcare, as well as some other services like WIC is in that building. So really looking at having some integrated care between the Mental Health Center and primary care is a really exciting opportunity for us to think about, and that they're just finishing the construction on that building now. I think they just did like the ribbon cutting today or yesterday. With COVID, I think there's a little bit of a delay in actually getting the providers in there and getting up and running, but hopefully soon they'll start seeing patients at that location.
So at any given time, there's close to 7,000 adults that are served through 39 contracts in adult behavioral health. Like Cindy said earlier, there's a range of services that we contract for, and under those 39 contracts, we have a continuum that offers everything from supportive housing and employment to intensive care, such as assertive community treatment teams, are called ACT teams, and intensive residential treatment services. A really important part of the service continuum is our contracted case management. Similar to children, it coordinates access to needed medical, social, educational, vocational, and other necessary services. Together, they provide, case management alone provides support up to 4,500 individuals at any given time. So this is a fairly large area for us. Hennepin County's 7 community support programs also serve around 2,500 individuals. They have a variety of supports that include drop-in access to housing and employment, as well as activities to promote health and wellness and community connections. Sometimes you'll hear them referred to as either a hub and spoke model or about a year ago, the programs, because of COVID, had to pivot their on-site offerings to a virtual format, and they delivered really innovative outreach and engagement strategies to keep people connected to mental health while they were, experiencing a lot of isolation. They kept members informed about their resources throughout the entire pandemic, and we're really grateful that that we have, they're called CSPs, out in our community. We use the Racial Equity Impact Tool to incorporate recommendations from our local advisory council. There's a statute that requires that the county responds to gaps in our mental health system, unmet needs, and requests from our local advisory council that includes people with lived experience, providers, and family members. It directs the county, our local advisory council directs the county to be more inclusive of communities impacted by racial disparities, and to expand culturally and linguistically responsive programs. This means that people living with mental illness participate in our RFP process, our request for proposal process, and will provide technical support to new providers representing Black, Brown, and Indigenous people. Next slide, please. The county directly operates 9 teams of case managers, so close to 100 staff. We serve approximately 1,000 people at any given time. I mentioned earlier that functional assessment is a really important part of understanding a person's needs. And so these teams develop a functional assessment and they complete individual community support plans. They help people access and coordinate necessary services that relate to their overall functioning. One of the main areas of focus for these teams is to support people under what's called civil commitment. And they also support individuals seeking assistance voluntarily, but by far the most common condition under which we're providing, county operated staff are providing case management is for people that are court ordered. Our teams are mobile. We offer multidisciplinary support that includes licensed social workers, alcohol and drug counselors, registered nurses, case management assistants, vocational specialists, and peer recovery specialists. We offer 2 diversion teams that offer alternatives to commitment through intensive case management. Our teams are culturally and linguistically diverse. They, like children's mental health, operated case management, are highly skilled. They know how to navigate these systems. They are very experienced in engagement and offering people choice and coordinated supports that are recovery oriented and person centered. The goal of the teams is to help people manage their symptoms and to function in their homes without the need for institutional care. Next slide, please. So one of the big things that the county took on about 7 years ago is this intersection between health, human service, and public safety. So back in, I think it was like 2015, we brought key stakeholders together and we gathered a bunch of data from multiple states, counties, city systems, and we created a process map of the criminal justice system, completed an environmental scan of what was working and what wasn't working. We took a look at national best practices across different jurisdictions that included Houston, Miami-Dade, Los Angeles, Chicago, and New York City. Once we collected all this information, we stood back to look to see what all this information revealed about the system in place in Hennepin County. And what we found was that our system is fairly fragmented and that overall, these 3 huge systems, health, human service, and public safety, tend to work in silos. And unfortunately, we spend a lot of time intervening at crisis points and at later stages in a person's mental illness. We also found that the traditional models of care were failing people with more complex mental health conditions. You could see through our data, pretty sweeping patterns of people that were cycling through inappropriate criminal justice venues and pretty high cost healthcare systems. For many, the jail itself became a pipeline to the state hospital system. Next slide, please. So one of the things that we did was we adopted a nationally recognized model for our framework of change. It's called the Sequential Intercept model. It comes to us from SAMHSA, Substance Abuse and Mental Health Service Administration. And what it does is break down the criminal justice system into 5 distinct, but they're kind of overlapping phases or touch points that we're now using to target efforts to disrupt the cycling effect that we can see. Each point across the criminal justice system is an opportunity to intercept people and set them on a path for recovery. So at each intercept throughout this system, we're building a pretty robust response using professional mental health social workers. This is an integrated approach to engage residents, to assess their needs, to connect them to vital supports, that will help stabilize their conditions and minimize further involvement in the criminal justice system. The sequential intercept model focuses on system change within public safety, but even the first intercept involves a law enforcement encounter. So the State Department of Public Safety and local law enforcement agencies regulate the 911 system. And the current response, as most people know, is threefold. It's police, fire, and EMS. Hennepin County is trying to go even further upstream, so we would call that like Intercept 0, to redirect people away from law enforcement encounters where we can. In 2020, so just 9 months ago, the county board created a task force to study the whole emergency response system, how it's regulated, and then to bring forward recommendations for improvement. What we're in the process of doing is trying to redesign the county's 911 system so that emergency response is tailored at the municipal level, that will meet each unique caller's needs, will bring the right professional, and resolve both the immediate need and the underlying drivers to the call itself. Our report is due back to the board at the end of this year, 2021. One of the things that that we put in place back in 2019 was something that we're calling embedded social workers. There were 6 cities at the time that came forward to the county to ask to partner with us for a new response to these mental health calls, and to provide some response in the field. So key leaders across these different cities were raising some fairly concerning points in the system that they were asking for partnership around. One was that there's this over-reliance on law enforcement to respond to mental health calls, which is putting residents and officers at risk for unnecessary and avoidable law enforcement contacts. They were concerned about working with people living with mental illness that they don't have the right training. And as we know, working with individuals in mental health with mental health conditions requires specially trained professionals that clearly exceeds the training of our law enforcement personnel. Residents shouldn't wait until a problem hits a crisis point to get help, and that there's an over-reliance on law. This over-reliance on law enforcement results in an overburdened police department and underserved residents. So we started by embedding social workers, professional mental health workers, into these various police departments. The collaboration is allowing for a tailored assessment and response for a 911 call. Police and social workers are now relying on each other's expertise to identify needs and get people connected to resources. Our hope is to prevent the next call and future arrests. The model is now expanded to 12 cities and 7 more police departments are interested in participating. Through the use of ARP funds, we expect to expand this program to every police department within Hennepin County. We're focusing primarily on our suburbs because Minneapolis is trying to test out a different response. And both of us are learning from each other in this. On this map, just to kind of orient you, the blue sections in the map represent cities that are currently participating in the program. The darkest toned cities are where the most mental health related calls are coming from, with the exception of Minneapolis. And the lightest colored sections are the newest cities that are participating in having an embedded social worker in their police department. Next slide. Some of you might be familiar with this, but the county owns a building at 1800 Chicago. Most people know 1800 Chicago for an old antiquated model of detox. That's usually what the communities understand that building to be. But in 2016, the county board approved renovations to the building, and that started a multi-year project to transform the facility into a behavioral health center. It's kind of like a urgent care or stabilization center. The building, if you're not familiar, is located in South Minneapolis. It's really close to the public safety facility, HCMC shelters, and a whole bunch of community service providers. At this location, we already had like county case managers, vocational specialists, and economic supports serving residents with mental illness and substance use disorders. So the first step in the renovation was on the 3rd floor. That's where we had that detox program. That's operated by the American Indian Community Development Corporation. We expanded their capacity and changed the service model into a 60-bed Medicaid-funded withdrawal management program. Then next, we opened up a 16-bed mental health crisis residential program on the 2nd floor. We also contract with an agency to deliver those services. We contract with Reentry House. And then the 3rd and final stage of the renovation was completed in 2020, where we established a walk-in clinic on the 1st floor. And so now individuals can either walk in on their own, police can drop them off. The entire capital project renovated about 4,200 square feet. And included replacing, mechanical, plumbing, electrical systems throughout the building. And the building is now completely transformed into a specialty center specifically for people living with mental illness and substance abuse. This slide is just, showing how 1800 is attempting to fill a gap in care. I mentioned it functions kind of like an urgent care center with people with mental illness and co-occurring conditions. It's really critical for law enforcement because it operates as an alternative to jail, and it's open to anyone in the community. The environment was designed with ongoing input from our community, residents that were likely to use this center. I mentioned earlier a local advisory council, and then key stakeholders from across health, human service, and public safety agencies. We have 5 contracted agencies providing support there, including Hennepin Healthcare. All of us are working together to provide holistic and integrated person-centered care. It's a really cool environment in that it's not only co-located and multidisciplinary, but the approach, we always talk about this a lot. We talk about like each discipline is expected to change its practice and break away from the traditional models of care. We want them to like bend it in a manner that delivers services that are tailored for and driven by the person seeking help. The person is forming our practice model. Next slide, please. I mentioned earlier that ARP funds are helping to expand a range of services. The county board recently approved $20 million in ARP funds. This chart is showing you the breakdown of how we are distributing those funds across the continuum of mental health supports that you've heard. Yeah, this is our last slide. The main focus is trying to target funding towards residents that have been disproportionately impacted by COVID and by already existing disparities. We're trying to lower barriers, improve outcomes, and expand our capacity. The whole vision of these are to focus on early intervention and to try to prevent the over-reliance on these deep end services driving disparity reduction. And the other core component of all of these is that it will require us to build partnerships, stronger partnerships across health, human service, and public safety systems that are needed for widespread system reform. That was our last slide, I think. And hopefully there's still time for questions. We realize that was a lot.
Wow, thank you all so much. I admit when I saw 32 slides there at the bottom, I thought, oh gosh, but really it's a wonder that you were able to fit so much information into 32 slides, and we are deeply appreciative Committee members, this was really good stuff. So please raise your hand. We can start a round of questioning. Go ahead, Laura.
Thank you so much for all of the background and content. I learned a lot about the array of services. I heard you talk a lot about trying to work away kind of or outside of the medical model. Working in a health system myself, I really appreciate that, not kind of over relying on that kind of medical Western. Can you talk a little bit about outcomes that you're seeing or ways that you are starting to measure success around some of the work you're doing or the models you're using?
Meredith, do you want to speak to some of the stuff that you're doing? I'll pull up some of my outcomes for some of the things in adults. And Cindy, I don't know if you have some outcomes that you want to talk to.
Yeah, I mean, I think for us, the work that we're doing between our public health nurses and like screening and doing health assessments for children that are in out-of-home placement, we are trying to move further upstream. So we know that that population is one that we want to pay specific attention to and do those screenings and connect them to resources. And also we want to expand, and we will be able to do that with our ARP funding, to look further upstream so that, you know, when families are coming in, maybe they're getting connected to economic assistance or the parent support outreach program or something that doesn't have to do with child protection, that we're able to identify those families and then be able to connect them with our public health nursing team to do screening and referral and follow-up. So we are just now starting that expansion, so we don't have data yet, but the measures that we would want to look at are, you know, number of screenings, number of referrals that are done, but then also trying to look at, and this is, I don't know how you would get at this, but like making sure, is there a way to look at like those families that may have had some interaction with child protection, but didn't end up in out-of-home placement? So,
yeah, so like avoiding crisis is
yeah,
the
right.
measure of success.
Yep.
Okay.
Mm-hmm. So I mentioned assertive community treatment teams, and I'm gonna zip through a couple of slides to give you some stats around that. So, so for example,
Leah, I have to stop you there because
sure.
This is a public meeting. You cannot put up any slides that were not previously provided to us. Because the city clerk's office requires for open meeting laws that all material is available more than 48 hours in advance of a meeting. So
Sure.
You can talk through your slides, but
That's
you can't.
exactly right. Yep, that's exactly right. I was just going to refer to some of them. So
okay, sorry, I misunderstood you then.
No, that's okay. And if you are interested in reviewing both of the presentations that were given to the board, from which the material that was presented today is coming from, both of those are public and available on the county website as well. So just if anybody wants to refer back to these slides or the outcomes, they're already public. Okay. So
yeah, and maybe Meredith, you can send me the link after the meeting, and then I would be able to provide it to the committee. Thank you.
Okay, so I'm just going to read from the slides that I have. So for example, with assertive community treatment teams, there were, in this particular study, there were 70 individuals served. 85% of those 70, so I can't do the math off the top of my head, but 85% have remained in stable housing. 95% have been connected to health insurance and medical care. 65% are employed, and 32% maintained employment. So that's, you know, that's just one program that we're mentioning about, you know, some of the positive outcomes. There were also really significant positive outcomes with our embedded social workers, where we pulled some data from Brooklyn Park, and we identified the top 25 highest callers to 911 that were calling for a mental health crisis. After they started working with one of our embedded social workers, we were able to reduce those calls by 85%.
That's awesome.
Yeah, and the way though that we did it was because we were connecting them to a bunch of services. So, you know, we connected. We made over 1,200 care coordination connections, employment, legal, economic supports, provided transport, assisted with mental health services, substance abuse treatment. You know, one of the main objectives with the embedded social workers is to try to get people that haven't been able to either navigate the system or get access to services, to get connected to those services so that they're able to meet their needs, you know, and remain stable in their communities. With 1800 Chicago, we studied 550 people. I don't have the total number of people served, but we did like a pre and post, and we were able to find that for people that came through our walk-in clinic, 35%, there was a 35% reduction in jail bookings. There was 29% fewer hospital admissions and 40% increases in mental health supports. So this is just a smattering of some of the outcomes that we've been able to see. One of the fun pieces about working across health, human service, and public safety is that we look through the lens of all those different disparity domains. So we are pulling regularly, you know, the connections to health, housing, justice, employment, education, transportation, because we're really trying to study this from a system transformation standpoint. You know, we're enhancing the services with different programs, but collectively we know that that one program isn't going to produce the kind of outcomes, especially for really complex populations. And so so this is the benefit of being able to look more completely at our system efforts. So those are just a range of outcomes that we've been able to track. Cindy, I don't know if you want to add. Mm-hmm.
I think that the outcomes for kids are similar. The services that we're starting to pilot, we're just starting, so we don't have the depth of now information that Leah just shared.
Okay, thank you so much for those responses. I'm seeing Babette and then Aaron. Aaron, I would have been you first, but your hand went down and then it's back up again. Okay, and then James Riley is third. And then, just in the interest of time, if you're gonna have questions, go ahead and get them up, because after James, I'm thinking that we'll wrap it up and we'll move to the next section on the agenda. Go ahead, Babette.
Thank you. Fantastic presentation, and very impressed with the depth and breadth of the services that you provide. So thank you very much. I have a two-part question. The first is, it seems to me that one of the challenges that people face, particularly as they're beginning to experience a mental health issue or a family member, is where do I go? Where do I turn? And I'm wondering if how you are helping the general population understand how to access these services, particularly with your impressive focus on trying to get upstream. And then also, I'm wondering how you are viewing and preparing for 988.
So Meredith, I don't know if you want to speak about public health promotions. Would that be a good place to start with?
Because of the nature of our work, where we're actually doing some routine, like the nature of screening is that you're looking at things before something actually comes up. I mean, it is early identification, so I don't know that the question is as relevant to the role of public health with like early identification, but certainly there are times when families know that something might be, like there's something going on with their young child, or infant or young child, and they don't know what to do about it. So there's a lot of information out there in the public domain statewide around, I don't know if you've heard of Help Me Connect, or Help Me Grow, which is basically if you've got any questions about your child's development, you can connect, and it's a phone number you can call, or you have a local number for Help Me Connect. And that, even though it's not mental health specific, they are able to, like that is a way into, it's basically a referral mechanism into additional screening and or assessment or resources. So for the young ones, birth to 5, there's definitely ways to do that in the public domain. And I don't know, Cindy or Leah, if you guys want to speak to Front Door, or if you want to talk about that for Hennepin County.
Yeah, so there's so Hennepin County operates something called the Front Door Social Services, where anybody can call in and receive, information, consultation, referrals, support, etc. And that's available, Monday through Friday, regular business hours. One of the things, though, that I think is really key to getting the word out about where do I go for help, how do I get help, is you heard both Cindy and I talk about that we're trying to partner with these natural access points. So schools, that's a huge conduit to helping families know where they can get help. So our school-based mental health program is really critical in that. The work that we're doing with child protection is another avenue. We serve a lot of families in child protection where either the parent or the child has a mental health condition. So, being able to like make that encounter count, so that we can help walk them through where to get services. Same thing with, all of the work under both juvenile justice and in the adult justice realms, where as people come into contact with different county systems, we're able to help them navigate and quickly assess and get them into services. That's a big part of our strategy. And then one of the things that is coming through ARP is it's a mental health campaign where, we're going to focus quite a bit on suicide prevention, because that was such an explosive thing, especially with young people over COVID. But in that, we are also trying to consider how we can create a public health campaign or a mental health campaign that also directs people to services, including when 988 rolls out, or when to call 911, or when to call COPE, or that whole realm of trying to create, through social media and through, avenues with like, bus stations and air broadcasts and things like that. How do we start to get the word out, one, around where they can access services and reducing stigma, to make it okay to reach out for those supports, because it still is quite a feat for somebody, to pick up a phone and call. So we're again, just like so much of our work, we're trying to come at it through multiple angles.
That sounds really good. That, to change that statistic that generally people on average wait 10 years before accessing services. Are you preparing for 988? Are you actively preparing for that?
Yeah, we're certainly at the table. There's a variety of structures that are trying to connect in. And part of the work under this 911 task force that I talked about earlier is to try to fit all these resources together so that they're aligned and they make sense for our residents. So in the process of looking at 988 and looking at 911 and looking at COPE and embedded social workers and 1800, we're trying to figure out from the user experience, from the resident experience, so it's kind of that end to end, how do we fit all these things together? And that is certainly under the charge of this task force.
Thank you. We do have to move to Aaron's question and then James's question.
Well, that was a perfect segue into my question, which is, what are the biggest obstacles at this time to fully integrating all these different services. It seems like you have multiple jurisdictions here. You mentioned municipal, state, county, as well as being involved with different agencies, you know, police, human services, public safety. You know, what are the biggest obstacles at this time? Are they bureaucratic? Is it actual legal jurisdiction, funding, political will? If you could
Right.
kind of just speak on that, you know, what challenges is your task force facing?
Yeah. I'll tell you what's fantastic, what's working really well are those partnerships across all those jurisdictions. I will tell you, we are really, really fortunate in Hennepin. I've worked across this country in this space for many years. And certainly what we have in Hennepin with our partnerships and our relationships is to be envied, for sure. You know, you're talking about at times very adversarial environments. And that is not the case in Hennepin for the most part. The barriers, you know, are more issues around like change management, you know, communication, right? So how do you get the word out? There's so many resources. So like, how do we inform the public about all that we have to offer? It's a huge challenge, right? So what are we doing about that? And then in terms of the alignment, you know, there's quite a bit of work to do around our data infrastructure so that we can respond, you know, kind of breaking away from those siloed approaches, that our capacity to be able to see either an individual see them through multiple systems or collectively on the aggregate to make sure that that we're not like creating policies. Like I'll be over here in human services creating a policy and I've just completely screwed something up over in the criminal justice system. So how do we have these data infrastructures that start to show the system working together? And that just takes time. You know, it's a lot of work, and these are really complex systems and complex structures. So we're on the right path, but it's just going to take us a while. So
can I add one thought to that? So I have a very specific barrier that we see come up, especially with infants and young children. And Cindy, this might be true for your group as well, is actually the number of mental health providers that can actually provide services. Mm-hmm. So we get kiddos that are referred for further assessment and are on a wait list for 9 months to get a diagnostic assessment. 9 months. That's and when you're having a mental health crisis or not quite sure what's going on, like that is a problem. Yeah. So that's a big barrier.
Yeah, and that's gotten way worse because of COVID. We already had workforce shortages in the mental health realm pre-COVID, and now post-COVID, it's really difficult for community agencies to hire and retain staff. That's a very, very serious problem. The other thing that I would say is along the lines of culturally specific providers, we know that we have huge disparities with our BIPOC communities, and we are working, you know, diligently to try to bring online a network that is representative of the range of cultures that we have in Hennepin. And again, we have a long way to go in developing that broad network. So those are some really key barriers for us, for sure.
Thank you. And then James, you'll have the last question. And if you would just take a brief moment to introduce yourself ahead of asking the question, because I don't recognize your name. You are on mute if you are currently speaking. Okay, perhaps. Oh, there you are. Go ahead.
So I'm actually on the phone right now, wondering if you can unmute my phone.
Did you come on as anonymous?
It may be, yes.
No, we are not able to unmute people. I remember this from our very early training on Teams.
And the reason I say is sometimes I have problems with the display here.
We can hear you though, James, just so that you know that.
Okay, well, I'll give it a shot then. Hopefully I can finish. Regarding slide 26, I don't know if you can pull that up or not. I had a question regarding what are the county's plans for coming into compliance with Travis's law as far as mental health crisis calls.
Yep. Yep.
On slide 26, that approach seems.
Yep. So.
Hello.
Oh. I can take that one. So.
Hello.
James, can you hear us? Because Leah is going to try to respond to your question.
I can hear you.
Perfect.
Oh,
all right,
okay.
Leah, take it away.
Okay, so yes, we have been watching that bill progress. It was passed last legislative session. We maintain a pretty close relationship with NAMI around this. And what we're trying to do is, again, to integrate all of these different mental health responses, many of which are mobile, into the 911 they're called PSAPs, the 911 centers. So the Travis law, as you are probably aware, says that 911 will direct mental health calls to mental health professionals. And so this is part of this task force work to try to identify, and it gets really complicated really quickly, but to identify mental health related calls and then to get them to the right response. Sometimes, say a person will call in and say, I'm having shortness of breath, and we think it's a medical call, and it turns out to be, an anxiety attack or something that requires a mental health support. The same could be true where it looks like it's mental health and it's a medical condition. So if a person calls in saying, I'm having a panic attack, and it turns out that they're having some underlying health condition. So we're trying to tease through all of that to make sure that that we bring the right resources. We're piloting a bunch of different responses. So you've already heard us talk about the embedded social workers. We have COPE. We're looking at piloting how to connect more closely with our EMS system. And all of that is in the plans for testing and then implementation in, whoops, did we lose him? In 2022.
Thank you very much for that, Leah. James, I hope you were able to catch that full response.
I was not.
Okay. Okay. Well, this is recorded, and so that response will be made available on YouTube. Unfortunately, we are over time substantially. And so to be respectful to our presenters and to the rest of the agenda, I will ask that you check that recording or that you just reach out to Leah directly by email. Would that be okay with you, Leah?
Yeah, sure, of course, yeah.
Wonderful.
Thank you.
Yes, of course. Thank you for that great question. I actually had the same question about the response. I thought, well, the 911 should go to COPE or whatever. So I appreciate you asking. Thank you very much, Leah, Meredith, and Cynthia for that wonderful presentation. I don't usually let presentations go over, but that one was too good and too beneficial to the community, to the committee. So I'm very, very appreciative. Thank you very much.
Yeah, thank you for your time.
Thanks for the opportunity. Thank you.
Absolutely. Okay, so we are going to move to the next item on the agenda, which is breaking us into subcommittees to work on those identified priorities. Now, just before the meeting, I sent you all a Google Doc that you should have access to, where we can collaboratively take notes within those breakout groups on what our actions are, if you have any, what you might want for additional information, or really whatever you feel like you need in order to advance on either a priority that's in the general purview of your subcommittee, or since you have access to the entire doc, If you feel like you want to scroll up or down and lend some thought to another area, that is totally A-okay. It's a Google Doc. It's not, anything that serious. So the way we're going to do it, because I want to make sure that if you wanted to move to a different subcommittee, you'd be able to. Hattie, I'm going to ask that you call the roll or go down in order of the roll. And committee members, you can just let Hattie know if you'd like to be moved into racism as a public health crisis subcommittee. I'm echoing a lot on someone. Of the environment and medicine subcommittee, or the third one, which I need to pull up.
And just so you
food, drink, and medicine. Okay, go ahead.
Are you saying go ahead to me? Sorry, I was changing my headphones. So what you want me to do, just do the roll call, and then people are going to tell me what subcommittee they're going to be on?
Correct. And then you are going to move them into those breakout rooms.
Okay.
And maybe 10 minutes before 8, we'll come back to get Gretchen's report.
Jerome, can you just tell us again what the third one was? It kind of broke up when you were listening.
No problem. It's got this weird thing where my notes keep moving away. It's the first was racism as a public health crisis. The second is environment and mental health. And the third is food, drink, and medicine.
Thank you.
No problem at all.
Jerome, one other question. Could you indicate in the Google Doc which topics go into which subgroup?
I can do that. It will take a second because I've just got a couple of screens going. So I say go for it now, and then you can move if necessary. Would that be okay for you? Was that Anna?
Yeah, thank you.
Okay, no problem.
Okay, Marianne Jones.
I'll do the Environment and Mental Health Committee. Thank you.
AJ Starr, did she ever join us? I don't think I saw her. Mary.
Food, drink, and medicine.
Kozar.
I'll go with the first committee. Thank you.
Hannah Arkin.
I'll go with racism as a public health crisis.
Fatima.
Racism as a public health crisis.
Laura.
Racism as a public health crisis.
Jerome.
Leave me in the general for the beginning, please.
What? What? I'm sorry.
Oh, leave me in the main room for the beginning, for just the beginning portion. We had some people who didn't move themselves this time.
Andrew.
Food, drink, and medicine.
Which one did you say?
Food, drink, and medicine.
Food, drink, and medicine. Okay. Wanda, did you join us? Meredith?
Food, drink, and medicine.
Greg?
I will do the environment and mental health.
Did I see that Babette joined us?
Yes, I'll do racism as a public health crisis.
Aaron?
Environment and public health. Or mental health, rather. Sorry.
Angeline?
Racism as a public health crisis.
Okay. Is that everybody?
That is everybody. Please break us up, and then feel free to take your 2 or 3 minute break once you're in your breakout room if you need it to handle any human needs. But we're coming back at 50 after. Let me get those titles.
And people can go ahead and go now because it's going to take me a few minutes to get people assigned to rooms.
Okay.
So you don't have
take
to
a break.
Yeah.
Babette, if you're still around, which group was it that you chose while Hattie is getting our groups organized?
Margaret, I'm pretty sure she chose racism as a public health crisis. Yep.
I was trying to also keep a list on the notes as to who chose which categories.
Yep.
We need to have some good music during this time. Typically, all that goes off in my head is, the Jeopardy, music as they're waiting for people to write their answers.
Sure.
So it seems like outside of racism as a public health, there's small groups here.
Mm-hmm. Yeah, it looks like 2 or 3 in food, drink, and medicine, and 2 or 3 in environment and mental health. Of course, we've got at least 4 people missing, I think. 1, 2, 3, 4, 5. As people RSVP'd with me, if I was on their RSVP, I did write back to them and say, hey, if you haven't had a chance to respond to Jerome's email about ideas, resources, actions, etc., please, take some time to do that so that we get their input. And I think it's a good idea for us to reach out after the meeting, to ask that same question, just to make sure that all voices have a chance to provide their input. And Jerome, you maybe got emails from people that I wasn't, people might not have CC'd everybody, so.
We did, well, I BCC'd everyone except for us, so they wouldn't have been able to get it. You would have been one of the only people to have gotten those responses, but it was really just Babette and Laura who responded back, which is what prompted the Google Doc, because I thought, well, it's a crazy time. The world seems like it's on fire. You don't have to respond to my crazy.
It literally is on fire.
Yeah. And it's nice to get together with peers to talk through these issues and kind of vet your own ideas before they get put down on paper.
I'm just happy when things work lately. It seems like the entire corporate world, just nothing gets done anymore. I don't know what it's like in government services, but it's like I can't get people to respond to emails. The mail doesn't work. Like, it's just, I don't know what's going on.
Yeah. One of my concerns, and maybe part of the reason why it always seems like I'm rushing us to do stuff, is that, I feel like you were appointed to take actions and create policy and the like. And I'm like, oh, we've spent months working on structure. I need to make sure people are getting to subcommittees and they are brainstorming and making the magic happen. And so,
yeah, and it's so much harder when it's not in person, because some of this we could have done like in 1 or 2 meetings, because you have everybody in the room. And we talked about this as with the co-chairs, is that you give people dots and then you get immediate feedback from folks, and this definitely adds and layers of responsiveness.
It's a tough time to be an advocate in this area too, because the politics has been so focused on other things. I mean, if we want to come talk to city council about public health, they're going to be saying we got bigger problems.
And they're all big problems right now.
Yeah.
So I think I have us all set. Did Andrew leave? Andrew Crook? I could not find him to assign him.
Do you move us to rooms, or am I in the right room, or I'm not sure what I'm supposed to do?
I haven't beamed this over yet.
Okay.
So are we ready? Are we ready for
We're
transport?
still waiting.
Are we ready for transport?
Beam us up.
Engage.
Make it so.
Yeah.
Oh, I see. Oh, I see people going.
Going. Wonderful. Okay, and those are both James, and that's Gretchen. Gretchen, are you there by any chance? Okay. I just don't want to have to rush her report. So if it turns out there's...
I am here, just putting new cartridges in my printer.
Always a challenge.
Well, taking advantage of this.
Yeah.
So, here.
You've still got time. I actually just wanted to make sure, did you have an extra long report this month?
I can usually, compress or expand given the
Could be a compression this month. No.
And Jerome, did people have any, do you feel like people in the rooms had enough direction in terms of like what needs to be
There's some direction.
So can you hear me now?
Yes.
Oh, yeah.
Yeah.
Okay. Yeah. So I'll use my headphones when I'm talking.
Okay. I'll let you get back to your printer in just a second. I just wanted to let you know it'll probably be a compressed report this month.
Yeah, I can give more or less detail. I'll be fine.
Okay. As long as you're set up for success. Thank you, Gretchen.
Jerome, are you heading off to a room?
Yeah, send me over to racism as a public health, please. Okay.
I'm sorry, which one?
Racism.
Okay.
Oh, I just get moved on mad that I can't hit a button.
Oh, there he goes.
Did we tell them how long they were going to be in the groups, or?
49. We should probably start bringing them back at 49, 7:49.
So I'll give them a warning at 7:47.
Sure. Is that what it gives us, like a 2-minute warning?
We can do whatever.
Yeah.
Whatever warning, because I just typed something in.
Oh, perfect. Yeah, I would give him a 2-minute warning. The reason I was giggling when he said, send me over to racism, I was like, that's probably one of the only times that you'll ever hear that positively talked about. It's like, send me over there. I want to go.
Can you move me to environmental health? Mary.
Oh.
She used the email.
It only leaves like 2 people in food, drink, and medicine. That racism group is quite large.
Andrew was here.
Yeah, Andrew and Meredith.
So is Meredith in there by herself?
Oh, I don't know.
Yeah, she is. Should I move
Send me over there?
Yeah, okay.
Chat with her.
Wait a minute. How did that work? Meredith, did you see Margaret in your room?
No. I'm wondering if you can move me to, I had the same thought as Mary, where I'm particularly interested in the vaccine hesitancy, and I think that might be in the environment and mental health group. I'm wondering if I can go there.
Yep, I'm gonna beam you over.
Well, thanks, Hattie.
Mhm. It said you failed to move. Try that. I think that beamed you. Margaret's probably in that room. I can't figure out how to get out of it. Hi.
Hi, I don't know what happened to Meredith when I got there. I was all by myself.
Yeah, she came back to this room right after you left, and then she asked to be put in the food room. So I just closed the other room so I could be back here.
Oh, okay. Gotcha.
The categories are not self-explanatory to me.
Yeah.
I mean, I understand the racism one, but the other ones are, without any description, seem nonsensical to me.
Yeah.
But,
Yes, I would agree.
Okay.
Jerome had kind of taken all the information off of a survey that we did with the PHAC members and sort of grouped them into these various categories. And several, I shouldn't say several, a couple of folks have said, is there a better way to organize these? Because for that very reason, they don't necessarily seem super connected. Because like I see food, drink, and medicine has access to dentistry and healthcare services, mental health, sexual exploitation prevention, public safety, and air quality. And so I'm not super clear on how do you discuss those through the category of food, drink, and medicine.
Mm-hmm.
So yeah, we'll talk about it at the next co-chair check-in again. You know, is that it's like, how do we make progress?
Well, and there's just too many.
Yeah,
there's too many categories. Yeah. I mean, there's too many items in each group.
Yeah.
Yeah.
Yeah, and that kind of goes back with what
they've
I was
chosen
saying.
Racism and public health. Clearly, that's a priority.
Yeah.
I mean, because all of them wanted to be in that group. So let's declare that as a victory, and the rest,
yes,
work yet to be done.
Yeah, and I think that goes right along with the comment that I made in terms of, yeah, if you only have like 2 people, you know, or 3 people in a subgroup, how do you yeah, how do you make progress when there's so many subtopics, you know, within the bigger category? And the fact that, you know, we're not doing any of this in person also just makes it challenging. It's like we could have this done in 3 meetings and we would have been rolling on, you know, and we've been working almost the whole year on prioritizing in one fashion or another. And I shouldn't say that. It hasn't been the whole year, but we started the year with asking members, especially new members, you know, like what is, you know, a big, public health concern in your area, you know, meaning like your ward or your, you know, representative area. And then we came back to that a few months later. And then we did the survey. So, yeah. We'll get it figured out.
Did this group already get an announcement of the City Health Award?
I can't swear to it.
Okay, this is on my list. I'm just trying to make sure I'm using my time.
Yeah. Let me.
But yeah, my list is not full of essential stuff. So whatever time I'm given, I can conform.
Yeah, and they did not like have, you know, super specific requests this time, which is why I didn't send you an email, you know, that said, hey, they want you to talk about these 3 things, you know, they just, they really wanted to be able to spend more time on this priority.
Yeah, because now they're already being called back.
Yeah.
Or not quite, but given the warning.
Yeah, soon.
Yeah.
So on a, here they all come. Wow.
Oh, we were just hitting the meat and potatoes of it. We were just getting
know.
What, you couldn't solve everything in 10 minutes? Yeah.
Okay, it looks like we are all coming back in. I do apologize for the brevity of that working meeting. We were interrupted in the middle of a really great thought, as a matter of fact, in the racism as a public health crisis group. I encourage all of the subcommittee members to exchange emails, communicate frequently, and then please know that your co-chairs understand that you need more time and that we will have whole meetings dedicated to this work, likely starting next month.
Yeah, I don't, we have no presentations scheduled for October.
You will no longer be rushed, and you are encouraged even to meet outside of this time, because you know you're taking on big stuff, and it takes a lot of thought. Okay, so I apologize for that. Now we're going to turn it over to Gretchen for the director's report, and I apologize, Gretchen, that you will have to be shorter than usual as well.
That's all right. Yeah, if you guys can solve racism as a public health crisis in 10 minutes, I can certainly do my report in 10 minutes. And maybe you had 12 or 13 minutes, I don't know. So just a couple things to be aware of this week. The department's budget presentation will be given to City Council on Thursday at 11:30. There's just a couple change items, or just kind of like new funding that the mayor's recommending, but it's also an opportunity to hear about our overall programming and how we're supported. So the mayor's recommending funding for the opioid development of an opioid community hub, and more funding for Inspiring Youth, which is one of our violence prevention programs. And then more funding for Rebuild Resilient, which is using some of our environmental health approaches and coupling those when businesses are trying to recover from the civil unrest and develop in important cultural business corridors. And also on Thursday at 1:30, so 11:30 is the budget. At 1:30, Public Health and Safety is going to have presentations, several presentations on public safety, including from the coordinator's office. So you'll be hearing about the city's version of a mental health response to folks who are in crisis and sort of where that's sitting, as well as hearing updates on the Office of Violence Prevention and some updates from the police department on crime statistics and how things are going in that way. So that, if you have time, or check it later afterwards, because it's all archived. The city received a gold medal from an organization called City Health. And this is an effort, a national effort to promote certain kinds of public health policy or policy that enhances public health, and then to evaluate to what extent various cities and counties have been able to do that. And so far they have identified, they had identified 10 who received gold medals, and now Minneapolis has been added to that list. Boston and Seattle and San Francisco, and quite a number of folks that we like to be compared to. And the city council received that recognition about a little over a week ago, and that we actually have like a gold medal. And I think there's a press release, so maybe Margaret, you can make sure that folks here at least get the press release, because it gives you some background on what kind of categories. Many of them are not things that the health department itself can pass, like complete streets. And so it's really also a testament to working with the community and working across the enterprise and making these changes together. Wanted to give you just a little update on COVID stuff. The rates are quite high. I have an email from Louisa, our epidemiologist, and so vaccine rates continue to inch up. In Minneapolis, 79% of those 12 and over have gotten at least one dose, and nearly 75% have gotten fully vaccinated. That compares to the state, it compares favorably to the state. The state is at 73% for one dose, while we're at 79, and fully vaccinated, we're at about 75, and the state is at 69. So we're doing well in the metro area. As an average, within that average, of course, as always, there are discrepancies. We are seeing a lot of cases. However, our 7-day average case rate is 24 per 100,000, and so that puts us up in the community spread category really high. We remember not that long ago when we were up there, and then we came down, and now we're way up. Our staff are getting so many cases for contact tracing, they can't keep up. Our rate is lower, however, than the state, which is at nearly 40 per 100,000, and we're at 24 per 100,000. So things are really blossoming in a not so positive way. We are also in the middle of testing and piloting a employee requirement for weekly testing that you can get out of if you're fully vaccinated. And we're starting with the staff at the convention center, and then we'll be moving across the enterprise and finishing that, or doing that for everyone. And then finally, I know that there's been interest in this group in having some young people as members of the committee, and 3 committees have been identified that are good candidates for a pilot. Public Health Advisory Committee, SEAC, who we have worked collaboratively with in the past, and then the South Side Green Zone. And we had hoped to get a CDC staff person to help us. We did not. We're not lucky enough to get one. They're in much shorter supply these days than they used to be. But I think we'll still convene a meeting of some of the staff that are connected to all those committees and just talk about how we might be able to move forward. Council member Gordon is very interested in this, and so there might be something we can do even if we don't have the staff support. So that's my pre-made list of things to talk to you about. Anything else you want to ask me about? I'm happy to answer in the next couple minutes.
I do. I have a quick question regarding vaccine or the testing option for unvaccinated employees. Will that cost be borne by the employee, or will it be borne by the city, the cost of testing?
We are not starting with it being borne by the city, and we are lucky enough to have free testing provided by the state at the convention center. Now, they didn't design that site to be an occupational testing site. It was more for community use, so we're working through that. But yeah, it would be very expensive to pay for that, and at this point, we're starting without that expense.
I believe that some private enterprises have the same model.
Do you happen to know what the breakdown looks like, or can you quantify the number of employees that you think that will apply to, or the number who are not vaccinated, or are you guys still in the process of determining that?
We are, that sounds like a great, easy answer. And it just hasn't proven to be. But people will need to fill out this attestation form. And so then we'll get a better sense. We can look at how many people use their health coverage to get a vaccine. We can look at various ways, but only parts of the picture emerge. And so we really don't have a full picture. But we're hopeful that it's pretty good. But recognize that there will be pockets, probably even within certain departments, that are less well represented.
Yeah, we're finding that in Hennepin County as well, that we couldn't figure that out beforehand with the data that we had, and we had to wait until the attestation forms were completed, and we're still in the process of that. But there's definitely a proportion of staff that are not planning to get vaccinated.
Mm-hmm. Yeah.
Okay, and then really quickly, because I have 30 more seconds, I believe I heard that Rochester schools were able to compile some data showing the percentage of their students that had already been vaccinated, and it was a pretty high number. Do you happen to know if, and I know Wanda's not here, so she would have a better idea. Do you happen to know if similar work is being done in our school system?
I don't know that. Louisa, our epidemiologists, are working very closely with the schools to handle outbreaks, and there have been quite a number of outbreaks and people needing to quarantine. We had to close Edison High School for 2 weeks just because so many of the kids not necessarily were infected, but needed to be quarantined because they'd been exposed, because in high school you move from class to class. I can ask her if there's something that we know, and if there is, I can share it. And if there isn't, if it's radio silence, you can assume that we don't have anything to share. How's that?
Sounds great. Okay, sorry, I went over to 8:01. My bad. Thank you all very much. Wonderful information. Oh, Margaret has one more thing to let us know, likely about re-upping, if you haven't already.
This is the last week to apply for your seat If you are interested in re-upping for an additional term, I sent out emails today and got positive responses from a number of people, so thank you for that. If you can get it in by Thursday afternoon, that is sort of our drop dead date. So please, if you're gonna apply, do it by Thursday afternoon, and I provided everyone with a link.
Awesome. Thank you very much. Next month, bring your readers, your notepad, your tea, because it is a working meeting.
Amen to that.
Thank you.
Thank you all. So great to see you.
Indeed.
Margaret, I have a question for you.
Yeah, Terry Ann.
How did my thing wind up saying that I was applying for the homegrown food council? Did I screw something up?
No, your application said public health advisory.
Yeah, I
committee.
read that. I'm like, I didn't even know there was a homegrown food council. Maybe I do want to be on that.
Yeah, I think the person who was taking, that application had probably just processed somebody who was interested in the
She was just,
homegrown food
he or she was
council.
just cutting and pasting.
She
Well, I'm
probably
glad I
just
copied you on it.
Yeah. It's
I just
happened
put
before.
the last second. Oh, I'm just going to copy her on it so she knows I did it.
You're not the
So-
first, that's for sure.
All right. Okay, cool. All right. Thank you. Bye, Hattie.
Yeah, you bet. Bye, everybody. Hattie, it looks like you remember